Good morning, students. Today we'll have two topics to be covered in this our series of injuries. We partly finished with chemical injuries, where we discussed the manifestations, acid and alkali injuries manifestations. We'll finish off with the management of chemical injuries, and then we will have an introduction of mechanical injuries. So, chemical injuries part. Treatment of chemical injuries is emergency, and the treatment lasts for many days. Treatment is immediate period management, first aid. Then it will be for the intermediate duration management and late management of the chemical injuries. Of course, it depends on the severity of the chemical injuries. So, medical treatment, aim of the treatment is to reduce the inflammation, promote epithelial regeneration, and prevent corneal ulceration. But basic principle is to bring the pH to neutrality by doing copious irrigation, which I think we have seen in the last lecture. So first principle, bring the pH to neutrality by diluting the contents by irrigation or by the irrigating fluid. Then starts this treatment of reducing inflammation, which is done by putting corticosteroid. So you have to remember corticosteroids are important for day 1 to day 10. You don't be under, because in ulcer corticosteroids are contraindicated, especially fungal ulcers. And any epithelial lesion, we generally teach that steroids are contraindicated. That is not the case here with the chemical injuries. Steroids are the mainstay of the treatment for first 10 days. So they are potent agents in reducing inflammatory reaction. They prevent the formation of excessive granulation tissue, which determines the development of symblepharon. Symblepharon is the adhesions between the bulbar and palpebral conjunctival raw areas. So these adhesions are prevented if you if the excessive granulation tissue is reduced. That is prevented by putting corticosteroid drops. They can be used, steroids can be used topically as drops or ointment for the first 10 days together with acetazolamide tablets to lower the intraocular pressure. The secondary glaucoma is important manifestation of chemical injury, which is prevented by giving systemic acetazolamide tablets. Hence, topical steroids may be used initially, usually 4 to 8 times daily, strength depending upon the injury, but must be tapered off after 7 to 10 days when sterile corneal ulceration is most likely to occur. So after 10 days you withdraw the steroids. Steroids are stopped as they impair healing, impair by reducing collagen synthesis and inhibiting fibrous migration and may precipitate corneal melting. So after 10 days there is no role of corticosteroid in the treatment of chemical injuries. Cycloplegia is a supportive treatment. You know, we treat ulcers also by giving cycloplegics. They improve comfort by preventing the spasm of the ciliary body. Then topical antibiotic drops, they are given for prophylaxis of bacterial infection. Superadded bacterial infections are prevented by giving, when you give topical antibiotic drops, which are to be given 4 times daily. Ascorbic acid and tetracyclines, they are given topically and systemically to enhance collagen formation. Tetracyclines, they stimulate the collagen synthesis by inhibiting the collagenolysis and stromal damage. So 10% sodium citrate, 5% N-acetylcysteine. N-acetylcysteine is mucolytic, or 1% medroxyprogesterone eye drops are useful adjuncts. So in adjuncts you have to think of tetracycline and ascorbic acid mainly. Now treatment of the complications. Symblepharon formation prevented by sweeping a glass rod as well coated with a lubricant. So in the fornices, go on sweeping a glass rod which is to be coated with lubricant. So that prevents the approximation of the two raw surfaces between the palpebral conjunctiva and the bulbar conjunctiva, so that they are well packed with the ointment. This procedure should be repeated several times a day depending upon the severity of the case. A fitting of a contact lens separates the two mucosal surfaces and prevents their adhesion. So bandage contact lens uh, will prevent again the adhesions between the two mucosal surfaces. Surgical treatments are needed to promote the revascularization of the limbus, restore the limbal cell population and re-establish the fornices. So if there is a limbal stem cell ischemia noted, one will have to go for limbal cell transplantation. If other eye is normal, limbal cells can be taken from the other eye, which is known as autograft. If both eyes are involved, they are to be taken from donor, that is known as allograft. So limbal stem cell transplant is important surgical treatment of chemical injuries because they help in restoring normal corneal epithelium, because diseased stem cells are replaced by the new healthy stem cells, which stimulate the regeneration of the normal corneal epithelium. Then there can be advancement of tenons with suturing to the limbus, which re-establishes limbal vascularity, which is known as tenonectomy, where you remove the again diseased tenon and healthy tenons you have to advance and it suture to the limbus. That again re-establishes the limbal vascularity. Amniotic membrane grafting is another surgical method. You have to remember, you can remember the principle only by when you graft the amniotic membrane, that will promote the epithelialization and it suppresses the fibrosis. Then gluing or keratoplasty may be needed for actual or impending perforation. So glue or uh, therapeutic keratoplasty may be needed for actual or impending perforation. But generally, one of the main complications of chemical injuries is a dry eye. So the keratoplasty has poor prognosis when it is done for chemical injuries. Late surgery is division of the conjunctival bands and symblephra. Then conjunctival or other mucous membrane grafting is another late surgery which is required. Correction of eyelid deformities such as cicatricial entropion. Then keratoplasty for corneal scarring should be delayed for at least 6 months and preferably longer to allow maximal resolution of the inflammation. A keratoprosthesis may be required in a very severely damaged eye. As a UG student, I don't expect much from UGs related to all these treatments. They can just mention principle in one line, but PGs I expect in detail about keratoprosthesis. Boston's keratoprosthesis or Kentucky, whatever different types of keratoprosthesis, how they work, what is their technique, and what are their complications of keratoprosthesis.